The goals of ambulatory anesthesia explains its popularity. The goal is to provide patients with safe surgery as minimally disruptive to their home life as possible and to allow them an early return to function. We also want to decrease healthcare costs by improving efficiency, and that's primarily by avoiding hospitalization. As a follow-up to my previous talk on ambulatory surgery keywords, here's a little bit I want to elaborate on what is unique when we talk about pediatric patients in an ambulatory surgery setting. For the details on pediatric anesthesia, I refer to my colleagues from the pediatric anesthesia division. So when pediatric patients are considered for your ambulatory surgery center, you have to make sure that the whole perioperative area is adequate for the pediatric patient population. That includes not only the surgeon and the anesthesiologist and the anesthesia provider, but also the perioperative nursing staff. You also may have to broaden your equipment needs. For monitoring, you need a lot different sizes of the equipment you use, but also for the whole environment, how you keep your pediatric patient occupied, distracted. And we all have seen the use of electronic gaming devices. They come very handy in this as an example for what you can do to make the environment a little bit more conducive to a pediatric patient. So speaking of environment, the whole facility needs to adjust to accommodate also pediatric patients. And the whole process needs to be conducive to pediatric patients and their caretakers. So from preoperative education and preparation of the patient for surgery, they both need to be included. The child, obviously, based on age range, but also the caretaker of what is the needs and the rationale for each step. Then perioperatively, not only in the immediate preoperative period, but also during the perioperative time, how we're communicating with the caretaker and making sure that they feel they have all the resources in place to take care of the child post-operatively. That's an education process which should start very early on before the surgical experience. So for pediatric patients to be candidates for ambulatory surgery, obviously there's an age limit, as explained earlier in my previous PowerPoint. Infants less than 60 weeks post-conception, or especially if they're born prematurely, or less than 6 months old, should not be cared for in outpatient setting because of the high incidence of post-anesthesia apnea. It can be as high as 25%. In this PowerPoint, I also want to emphasize, pediatric patients for ENT surgeries, if they present to you for tonsillectomy, children less than 3 years old also should be very much screened, and most times are excluded for outpatient surgery because of the high risk of obstructive sleep apnea in that cohort. Patients with upper respiratory tract infections, also very common in the pediatric population, but also in the adult population. The ballpark here is upper respiratory tract infection, more than 2 to 4 weeks previously, and symptoms have resolved. Those patients are usually candidate for ambulatory surgical procedures. However, since I said very common in the pediatric population, especially in the pediatric ENT population, we have to make a lot of judgment here. Okay. Patients are not candidate for ambulatory surgeries if they present with active productive cough, fever, lethargia, so obviously kind of like having an acute process going on. If they had a recent upper respiratory tract infection within 2 to 4 weeks and the symptoms have resolved, the risk of laryngospasm is still elevated, 2 to 20% depending on which study you believe. But in all studies, the issues are generally treatable without serious complications, and the unplanned admission risk is low. Patients in the pediatric ENT population, they may be never long enough symptom-free. So here, we loosen it up and say it's acceptable to proceed with a patient after a URI has symptoms are minimal or have resolved. Now, so how about patients with malignant hypothermia? Malignant hypothermia is just as likely to occur in a healthy patient in an ambulatory surgery center as in a medical complex inpatient. Overall, there's a low incidence of malignant hypothermia, and most of them we have a patient history or family history who can guide us in a leading direction. Malignant hypothermia patients can safely undergo outpatient surgery center if they're using non-triggering anesthesia technique, and they also can be discharged on the day of surgery if the anesthetic has been uneventful. The requirements are listed here. Any anesthetizing location, we have to have dantrolene available. We have to be able to perform a non-triggering anesthesia technique. There is no point in giving prophylactic dantrolene. You have to have a properly prepared anesthesia machine. While it's still unclear how long a volatile anesthetic may be present if you don't have an MIH naive or volatile naive machine available. The charcoal filters are seen as a reliable tool to exclude the contact of the patient with volatile anesthetic. The postoperative discharge time does not need to be prolonged. While there has been suggestion in the past to observe patients for 4 hours after surgery, this is really not necessary based on large cohort studies. There is MHouse and Samba combined have developed an MH algorithm, and there also has to be a transfer protocol in place with the hospital and in a transport carrier if we are talking about a isolated freestanding surgery center. So coming back to the system-based implications of considering pediatric patients for ambulatory surgery, how are we including the parents? The question the facility has to ask themselves, will we allow parental presence for induction? There are pros and cons for it, but the center should have a policy for this, and if you allow parental presence during induction, how will the parent be guided throughout the process? Also to consider is if there's an advantage of an early reuniting of the parent with the child in the early recovery process. It may facilitate for the child to return to earlier return to cognitive function and to reorientation. However, obviously can be a very traumatic experience for the parent to observe something like an emergence delirium. Also here, preparation and education are essential. When it comes to the management of an emergence delirium, I refer to one of the PowerPoints of our colleagues from the pediatric anesthesia cohort. The most common reason for discharge delays or unanticipated hospital admission, even in the pediatric population, are PONV and pain. So based on a very recent publication from T.J. Gang and his colleagues in 2020, here's a nice algorithm how to address the PONV in pediatric population. And as it is with adult patients, it starts with risk identification. The risk factors are listed here on the slide. And then based on this risk stratification, you know if it's low, medium, or high risk. and that determines the depth of your prophylaxis. And if someone fails prophylaxis or prophylaxis was not administered, you also then go on rescue therapy and you treat. This concludes my review on ITE keywords for ambulatory surgery. I want to finish with those two pictures from our Center of Advanced Surgery, our ambulatory surgery center here connected to the hospital, and then our isolated freestanding surgical center, our Lexington Surgery Center here on Turfland. Thank you very much.